Sir, we are on live, sir. We'll start in 1 minute, sir.
Sure.
Good evening, viewers. Happy to meet you all again in this wonderful evening. Today, we are having Dr. Vinoth Doraiswamy sir with us. Sir is going to deliver a talk about A to Z of ECG. This is part 2. Sir delivered a talk, first part, last week, 20th May 2020. If you have not seen this video, you can access in our YouTube page. We welcome you, sir.
Thank you very much, Dr. Karthik. Shall I start?
Yes, sir. We can go into present. Thank you, sir.
Okay. So good evening, everybody. So I'm Dr. Vinoth Doraiswamy, consultant pediatric cardiologist at PSG Hospitals, Coimbatore, India. So I'm going to take A to Z of ECG part 2. I'd like to thank the organizers for this opportunity. So in the part 1, we had dealt about what are the normal leads, how are they derived, what is the ECG paper, then how to calculate the heart rate, what is the sinus rhythm, and then we looked at complete heart block, QT interval. We looked at that, and then we also finished off with the QRS complex. How is the calculate the axis of the QRS complex? So now we'll proceed with that. So after the QRS complex, we're going to look at abnormalities in the P wave. So how to calculate the P wave axis? So we dealt with this in brief previously, how to calculate the P wave axis. So if you remember, I told you about sinus rhythm. For sinus rhythm, every P wave has to be followed by a QRS complex with a constant PR interval and has to have a normal P wave axis. So now it's important to calculate the P wave axis because an axis tells you from where the atrial depolarization is arising. A low right atrial rhythm can be a variant of normal. So if there's no P waves, it could be an atrial fibrillation, flutter, or an atrial standstill. So as with calculating any axis, we have to remember our hexaxial reference diagram in the frontal plane. So it's more than enough if you see just two leads like the QRS axis of lead 1 and lead AVF, but the other leads can also help us to know in which direction the atrial depolarization wave is going on. So now the low left atrial rhythm. So the low left atrial rhythm will come from the lower part of the. So I just want to tell you the normal sinus rhythm is the high right atrial rhythm because we know that the sinus node is present at the lateral wall of the right atrium at the SVC-RA junction, which is high right atrial rhythm. So that is the normal sinus rhythm. So now while coming to the low left atrial rhythm, so it comes from the lower part of the left atrium and it goes in the direction of the yellow arrow you can see at the hexaxial diagram. So definitely if you're considering lead 1 and AVF, lead 1 and AVF will be negative because it is going away from those leads and AVR will be positive. Then next is the low right atrial rhythm, which we saw an example of left isomerism. It goes in the direction of the red arrow. Okay, so in that case, lead 1 will be positive because it's going towards that and lead AVF will be negative and lead AVL will also be positive. The next is the high left atrial rhythm. So consider a situation where this situs inverses. So normally the right atrium is on the right side, left atrium is on the left side. In situs inverses, the right atrium will come to the left side and the left atrium will come to the right side. So now the sinoatrial node will be on the left side. That is on the right atrium, which is on the left side. So it will go, the atrial depolarization will have to go in the direction of the gray arrow. So lead AVF will be positive and lead 1 will be negative. So this is a high left atrial rhythm, which you see in situs inverses. So you can diagnose situs inverses very well from the ECG. And the next is the high right atrial rhythm, which is the sinus rhythm. Because the sinus node is situated in the high right atrium. So it goes in the direction of this brown arrow. So lead 1 will be positive and lead AVF will be positive. Lead 2 will also be positive. So this is the way in which you diagnose the P wave axis and from where the rhythm is originating. So we're coming to a few examples. So this is a 13-year-old male who is asymptomatic. So you want to calculate the P wave axis. So now the P wave we'll look first in 1 and AVF. Okay. So it is positive in lead 1 and negative in AVF. So we know that this is not sinus rhythm because it has to be positive in lead 1 and positive in AVF. So it is negative in AVF and negative in all the inferior leads as well, like lead 2 and lead 3 as well. So the direction of the P wave axis will be in the direction of the red arrow. That is, the lead 1 is positive and the lead AVF is negative. So this will be a low right atrial rhythm, which can be also present in normal and also in the left isomerism, which we had seen in the previous class. So this is a low right atrial rhythm. And of course, this is going towards the AVL. So you can see the P wave in AVL is also positive. Coming to the next example. So the P wave in lead 1 is negative and lead AVF is negative. It is also negative in the other inferior leads, that is 2, 3 along with AVF. And it is positive in AVR. So definitely the direction of the P wave depolarization is in the direction of the red arrow, which you can see in the diagram, where it's negative in the lead 1 and lead AVF and positive in AVR. So this will be a low left atrial rhythm. Next, coming to the next patient. So again, we'll want to calculate the P wave axis. So the P wave axis we'll see in first lead 1 and lead AVF. So it is negative in lead 1 and positive in AVF. It is also positive in the inferior leads. And it is also positive in AVR. Okay. So now the direction of the P wave axis, if it is positive in the inferior leads or positive in AVF and negative in 1, it has to be in the direction of the red arrow, which you can see the screen, and it is also positive in AVR. So this is the high left atrial rhythm, which I said you can get in situs inversus. So in situs inversus, basically you will have the P wave. P wave will be positive in AVF and negative in 1 and positive in AVR. So here you can see situs inversus with the right atrium is present on the left side. Okay, so definitely the rhythm will have to be a high left atrial rhythm. So I've also written levocardia. So if you see the QRS complexes, you can see a normal transition. That is, the transition is the place where the deep S waves of V1 will be going towards the tall R waves in V6. So normally the transition is somewhere between V3 and V4. So here you can see a normal transition around V3 and V4. So this is the levocardia. Now coming to the next example. Okay, here again we'll see the P waves. So P waves are again negative in 1 and positive in AVR, and also positive in the inferior lead. So this is again a situs inversus. So 2, 3 in AVF are positive. So this is a high left atrial rhythm and situs inversus. But now I want to turn your direction to the QRS complexes. You can see that the deep S waves in V1 do not become the tall R waves in V6. Okay, so this is a delayed transition, also known as a clockwise transition. Okay, so this is because the heart is not present in the left side of the chest. This patient is having a dextrocardia. So that is why there is a delayed transition. So you do not get tall R waves in V6. Another thing is V1 and V2 are the right-sided leads. So because those leads are towards the are nearby the right-sided heart, the complexes, the amplitude of those complexes are large. And because V5, V6 are on the left side of the chest and they are far away from the heart, which is in the right side, that is the dextrocardia, the complexes are small. So this is a poor R wave progression in the lateral leads, that is a delayed transition. So this is a high left atrial rhythm with situs inversus. So you saw previous ECG, a high left atrial rhythm with situs inversus, and levocardia, we have the normal R wave transition or a normal transition. And then you have the high left atrium situs inversus dextrocardia, where you have the poor R wave progression and the delayed transition. Okay, so this is an example of situs inversus with levocardia and dextrocardia, which we're able to find out from the ECG. Now we've seen the QRS axis and the P wave axis. Now we're coming to the T wave axis. So nowadays we don't calculate the T wave axis that much, but it's important to know what is the use of calculating the T wave axis. Okay, so after we calculate the T wave axis, the important thing is we have to calculate what is the angle between the QRS axis and the T wave axis. So normally the angle is less than or equal to 60 degrees. So if it is more than 90 degrees, it could signify either an ischemia, inflammation, or strain, or a channelopathy. So we'll take an example of how to calculate the T wave axis and the QRS T angle. Okay, so first we have to calculate the QRS axis. So we're going to take the isoelectric method. So find out which is the most isoelectric lead. So we see clearly that lead 1 is the isoelectric lead. So if lead 1 is the isoelectric lead, the vector has to be perpendicular to lead 1. So perpendicular to lead 1 is lead AVF. So it can be either plus 90 degree or minus 90 degree. So we take the help of the other leads. We see that lead AVF, lead 2 and lead 3 are all positive. So therefore the axis is 90 degrees. So QRS axis is 90 degree. Now we see the T wave. Okay. So the T wave, you see, where is the T wave? Isoelectric. So you see most of the leads T wave is positive, but if you come to lead AVF, here the T wave is isoelectric. You see a negative and then a positive, with the positive divisions equal to the negative divisions. So if the lead is T wave is isoelectric in AVF, then the T wave axis has to be perpendicular to AVF. So lead 1 is the one which is perpendicular to AVF. So now if it is a lead 1, it can be either 0 degree or it can be 180 degree, because that is the direction of the lead 1. So we see the T wave in lead 1 is positive. So therefore the T wave axis has to be 0 degree. So the blue arrow. So now the T wave axis is 0 degree. Now the QRS-T angle will be the angle between the red and the blue arrow, so which is definitely 90 degrees. And now the QRS-T angle, which is more than 6, normally it is QRS-T angle is less than 60 degrees. Here it is more than 60 degrees, so it is an abnormal QRS-T angle. So we've analyzed the axis of the P, QRS and T. Now we have to analyze individual waveforms. So coming to the normal P wave. Okay, the normal P wave has a smooth contour and it will be monophasic in lead 2 over here, and it will be diphasic or biphasic in lead V1. So why is it biphasic in lead V1? We know that when the atrial depolarization starts from the sinoatrial junction, it will go towards the anterior wall of the right atrium. Okay, and so V1 is an anterior lead, so the initial part of the P wave will be positive. Then after the right atrial gets depolarized, through the specialized internodal tracts, it will go and depolarize the left atrium. Now the left atrium is posterior to the right atrium, so therefore the later part of the P wave, which is due to the left atrial depolarization, will be negative in V1, because V1 is an anterior lead. So it will be biphasic in lead V1. The normal duration of the P wave is less than 3 small boxes or 120 milliseconds. Okay. So the abnormalities which are seen in P wave is 2 types of P wave abnormalities can be seen. The right atrial enlargement, where you get a taller than normal P wave. So either the P wave more than 3 millimeters or more than 2.5 millimeters in lead 2 or V1 is right atrial enlargement. And left atrial enlargement, where the duration of the P wave is more than 120 milliseconds. And many times you can see a notch also in the P wave. So when the distance between the 2 notches is more than 40 milliseconds, that is also a indication of left atrial enlargement. So this is one hump, and this is one hump, and the notch in between. So when the distance between these 2 humps is more than 40 milliseconds, it is called as P mitral. So that is also an indication of left atrial enlargement. So again, the right atrial enlargement criteria: P wave more than 2.5 millimeters or 3 millimeters or 3 small boxes, and there is a peak P wave in either lead 2 or lead V1. And left atrial enlargement is a broad notch P wave more than 120 milliseconds, that is 3 small boxes. And I told you the distance between the 2 notches, or rather the 2 humps, is more than 40 milliseconds or 1 small box. So that is P mitral. So this is the main criteria for right atrial enlargement and left atrial enlargement. Okay, so consider this 2-year-old boy with Epstein's anomaly of tricuspid valve. You have a severe tricuspid regurgitation. Okay, the first thing what you can see is you can have very tall peak P waves in lead 2 and lead V1, which is definitely more than 2.5 millimeters. So this boy has a right atrial enlargement. Then coming to this 24-year-old with a severe aortic stenosis and a bicuspid aortic valve. Okay, here you see the broad notch P waves in lead 2, okay, which is more than 3 small box, more than 120 milliseconds. Okay, so this patient has a left atrial enlargement. So when coming to the criteria for left atrial and right atrial enlargement, they're similar. They're actually similar in adults and children. So in left atrial enlargement, we saw that one is the duration of the P wave more than 120 milliseconds, and another one what we saw is the distance between the 2 humps is more than 40 milliseconds, P mitral. You also have one more criteria known as the Macrous index. You can see the third one, where the duration of the P wave, if you divide it by the PR segment duration, if it is more than 1.6, it is Macrous index. And if you have an abnormal P wave axis, so if you have a more leftward shift of the P wave axis, it is a left atrial enlargement, and a more shift of the P wave axis to the right, that is more than plus 75 degrees, is the right atrial abnormality. But I would like to show you the round which I put. We all know that the P wave axis is P wave morphology is biphasic in V1. So the initial is positive and the terminal part of the P wave is negative. So we know that the second half of the P wave in V1 signifies the left atrial depolarization. So if that negative part of that P wave is if the area subtended by that negative portion of the P wave is more than one small box, that is more than 0.04 millimeters second, it is a left atrial enlargement. And same if that initial positive portion of the P wave, which actually shows the right atrial depolarization, if that initial positive portion is more than 0.06 millimeters second, that is more than 1.5 small boxes, it is a right atrial enlargement. So these are also two important points concerning the biphasic wave in V1. So here is an example of an ECG. So first I'll immediately take you to the diphasic wave in P1. So you can see that the diphasic wave in P1, the negative portion is much more prominent than the positive portion, and it is more than one small square. So this is a left atrial enlargement due to the increased negative portion of the biphasic P wave in V1. So coming to the QRS complex. Okay, so QRS complex has different letters. So first is the Q wave. So Q wave is the first negative deflection in the QRS complex, which represents the initial septal depolarization. Now the first positive deflection, which is in the QRS complex, or the first positive deflection which presents after the Q wave, is the R wave. And the first negative deflection after the R wave is the S wave. Then the first positive deflection which is after the S wave is the R dash wave, and the first negative deflection after the R dash wave is the S dash wave. So if the amplitude of the QRS of the any particular wave like QRS is large, we use a capital letter or an uppercase letter, and if the amplitude is small, we use a lowercase letter. So we want to tell you how does the QRS depolarization proceed. How does the ventricular depolarization and repolarization proceed? So the first part of depolarization which happens is the septal depolarization, which happens in the left side of the interventricular septum and goes towards the right. Okay, so after that depolarization happens, then the depolarization will go towards the apex of the heart. After it reaches the apex of the heart, it goes towards the free wall of the right ventricle and the left ventricle. And after that, it goes towards the base of the heart. So the base of the heart is the last part of the heart to be depolarized. And regarding the repolarization, you must remember that the part of the heart which depolarizes last will repolarize first. So the base of the heart will repolarize first. And because the depolarization happens from endocardium to epicardium, the repolarization will happen in the opposite direction, from epicardium to endocardium. So the part of the heart which depolarizes last will repolarize first. Okay, so this depolarization can be simplified and tell us how we get the QRS complex. For example, now we see in the right sided diagram, you have the left ventricle and right ventricle interventricular septum. So you have the leads from V1 to V6. We know that V1, V2 are right ventricular leads, V3, V4 are the anteroseptal leads, and V5, V6 represent the left ventricle. Okay, so the first depolarization is the septal depolarization, which goes from the left to the right side. Okay, so now because this is towards the lead V1 and the septal depolarization is low amplitude, you will have a small R wave in V1. Okay, small r, not capital R. And in lead V6, because this septal depolarization is away from V6 and V5 lateral leads, you will have a small Q wave in V6. So this is known as a septal Q wave. Okay, then after that, the depolarization happens towards the free wall of the left ventricle and the right ventricle simultaneously. Okay, and because as I've told before, the depolarization of the left ventricle and right ventricle happens simultaneously, but because the left ventricle is thicker, the depolarization vector of the left ventricle will cancel out the right ventricle. So whenever two vectors are depolarization are happening simultaneously and they're in opposite directions, only the larger vector will be manifest on the ECG. So here, because the left ventricle is thicker than the right ventricle, this left ventricle depolarization will manifest on the ECG. So this is going towards V6 and away from V1. So you will get a deep S wave, which is a capital S wave in V1, and you get a tall R wave in V6. So this is basically the QRS complex in simplified terms. So coming to the septal Q wave. So I told you a septal Q wave is a normal phenomenon due to the septal depolarization. Okay. So when looking at this ECG, okay, we'll just blow up the ECG. Okay, and this is the lead one. So lead one has this is the septal Q wave. So one is also a lateral lead. Lead avial is also a lateral lead. So you have a septal Q wave in avial. Okay, because due to the initial septal depolarization. And the other lateral leads are V5, V6, and V7. All of them have small septal Q waves. Okay. So absence of septal Q waves can be a normal variant, but can also be present in left bundle branch block, how I'll explain later on, and also in L-looped ventricles. Okay, so we know that the left ventricle is on the left side and the right ventricle is on the right side. These are D-looped ventricles. So L-looped ventricles, there are certain congenital heart conditions where the left ventricle comes to the right side and the right ventricle comes to the left side. Okay, one example is congenitally corrected transmission of great arteries. Okay, so this is a 24-year-old asymptomatic patient with abnormal left parasternal pulsation and a single S2. So when he's having a single S2, definitely he's having a congenital heart disease, more likely. Okay, so first the abnormalities in this ECG, the lead one is positive and lead ABF is negative, so it is a left axis deviation. Then you have the deep Q waves or QS pattern in the inferior leads, 2, 3 ABF and in V1. Then if you take V6 lead, normally you should have a septal septal Q wave in V6, but this septal Q wave is absent in V6. So why is that? This is a patient who has a CCTG or congenitally corrected transmission of great arteries. Okay, so in the normal heart, we know the right atrium is connected to the right ventricle, then connected to the pulmonary artery, left atrium to the left ventricle to the aorta. So here in the CCTGA, the right atrium will be connected to the left ventricle, then to the pulmonary artery, and the left atrial will be connected to the right ventricle, then to the aorta. So it has a double discordance. So because of that, the left ventricle comes to the right side and the right ventricle comes to the left side. So now the septal depolarization wave will travel from the left ventricle, which is posterior and inferior to the right, to the right ventricle, which is anterosuperior and to the left. So definitely the Q waves will not be in the left-sided lateral leads. Okay, so that's why you have the absent septal Q waves in the left-sided lateral leads. But you will have Q waves or the QS pattern in the inferior leads because it's going towards the superior right ventricle. So 2, 3 AVF will have Q waves, like we have said, and V wave V1, which is also an anterior lead, will have a, so V1, which is a right-sided lead, will also have a Q wave because this septal depolarization is now going away from the V1. Okay, so this is a congenitally corrected transmission of great arteries where you have a absence of the septal Q waves in the lateral leads. Then coming to QRS duration abnormalities. Okay, so I previously told you that the normal depolarization waveform comes from the sinoatrial node through internodal tracts to the AV node, his bundle, and goes to the right bundle and then the left bundle, Purkinje fibers, and then will depolarize the right ventricle and the left ventricle through the specialized conduction system. So when this happens, when the right ventricle and left ventricle get depolarized by the normal conduction system, QRS complex will be narrow. But suppose any problem would happen such that the right ventricle or the left ventricle does not get depolarized by the specialized conduction system, but by muscle to muscle fiber to muscle fiber or cell to cell conduction, the ventricular depolarization takes place over a longer period of time. So the QRS duration becomes wider. So this happens in a right bundle branch block or a left bundle branch block. Okay, and intraventricular conduction delay. So you can have a right ventricular conduction delay, for example, in an atrial septal defect. Okay, we'll see that later. Or you can have an intraventricular conduction delay where you have a non-specific intraventricular conduction delay where you have a widened QRS complex, but that pattern does not fit either the right bundle branch or the left bundle branch pattern. So this can be present in myocardial infarction, myocardial fibrosis, or conditions like amyloidosis. Then a wide QRS with a sinus rhythm you can have in WPW syndrome, which we have seen previously. And ventricular arrhythmia. So if the focus of depolarization does not arise from the sinoatrial node, but arises from some portion of the ventricle, obviously the depolarization of the ventricle cannot happen with the specialized conduction system. So you'll have wide QRS complex. So we'll go through these one by one. So what happens in a right bundle branch block? Okay, so in the right bundle branch block, when the depolarization waveform comes to the AV node, his bundle, now there's a problem in the right bundle branch, so it gets blocked. So now the impulse can only come down the left bundle branch. Then after it comes down the left bundle branch, it will then here it comes down the left bundle branch, and now the septal depolarization can happen normally. So the septal depolarization which happens from left ventricle to right ventricle happens normally. So the initial part of the QRS complex is normal. Then after that, the left ventricle, because the left bundle branch is normal, the depolarization of the left ventricle also happens normally. So the middle portion of the QRS complex is normal. Then after that, the right ventricle will happen after depolarization will happen after the left ventricle, which happens by muscle fiber to muscle fiber depolarization because there's a right bundle branch block. So the terminal part of the QRS complex will be wide or will be slurred. Okay, so you will have an RS-RH pattern in V1 with a prolonged QRS duration, which is more than 80 milliseconds when it's above 4 years or less than 4 years or younger children, and if it's more than 12 years or adults, more than 120 milliseconds. And the terminal conduction delay will be anterior and to the right, because the right ventricle is the one which causes the delay in depolarization, and that is present anterior and to the right of the left ventricle. So that's why you will have a terminal conduction delay in the right-sided leads like V1, 3, and AVR. So now coming to this again, now when we're seeing the same right bundle branch block, okay, the impulse cannot come down the right ventricle, it comes to the left ventricle. Now if we see lead V1, the septal depolarization happens normally. So V1 is the right-sided lead. So you'll get a small R wave. Okay. Then after the septal depolarization, the left ventricle will depolarize normally. Okay. So V1 is the right-sided lead. So you'll get a deep S wave. Then after that, the right ventricle will get depolarized slowly by muscle to muscle conduction because of the right bundle branch block. So you will get a R dash, which is because the right ventricle depolarization is towards the V1. So you'll get an R dash pattern. Okay. Then now same thing when coming towards the V6. As I said, the right bundle branch is blocked. So now the impulse comes down the left bundle branch. Okay. Then the septal depolarization happens normally. So V6 is a left-sided lead. So the normal septal depolarization will be there, which is the Q wave. Okay. Then after that, the left ventricle depolarizes normally. So it's a tall R wave. And then after that, the right ventricle depolarization happens abnormally by cell-to-cell conduction, which is delayed. So the terminal part of the QRS complex is delayed. And because the V6 is a left-sided lead, you will get a S wave, and the slurring of the S wave will happen. So the terminal part of the QRS complex is only slurred, okay, because of the delayed right ventricular depolarization. So this is the right bundle branch block. So basically, you get an RS-R dash pattern in the right-sided leads, okay, and the terminal part of the QRS complex is only slurred or widened. So now you have a 5-year-old boy who is asymptomatic with a wide fixed split S2 and an ejection systolic murmur in the left upper sternal border. So if you have an ejection systolic murmur in the left upper sternal border with a wide fixed split S2, the diagnosis is an atrial septal defect. Okay. So these patients will have an RS-R dash pattern. Okay. It is a right ventricular conduction delay because the QRS complex duration you can see is normal. It is not more than 80 milliseconds. Okay. So this is called as an incomplete right bundle branch blot or right ventricular conduction delay, atrial septal defect. So why this happens is, you know that an atrial septal defect is actually a hole in the interatrial septum between the left atrium and the right atrium. Now there is a shunt of blood from the left atrium to the right atrium. So the right atrium and right ventricle enlarges. So because the right ventricle enlarges, it takes a longer time for the depolarization to go down the right bundle branch when compared to the left bundle branch. But there's no anatomically abnormality in the right bundle branch. So that is why you get the RS-R dash pattern, but the QRS duration is not prolonged. Consider this 1-year-old patient operated for tetralogy fellow. So you all know that a tetralogy fellow has the 4 components. It has the large VST, the overriding of aorta. It has the right ventricular hypertrophy and the pulmonary stenosis. So in order to operate that subvalvular pulmonary stenosis, you're going to have to cut through the right ventricular or right ventricular infundibulum. So it's many chances that you can damage the right bundle branch or the Purkinje fibers of the right ventricle. So that is why you have the RS-R dash pattern over here, and you can see the term, the small r, the first initial positive is R, it is small amplitude to a small r, then the S wave, which is also small amplitude, but the terminal R dash is of large amplitude. That is why it is a capital R dash. Okay, and the QRS complex duration is much more than 120 milliseconds. So because there's an anatomical abnormality in this, that's why you get a wide QRS duration in a post-operative tetralogy fellow. It's quite common. And now the V6. So in the V6, you can see that the terminal part of the QRS complex is delayed. So you get the slurring of the S wave of the V6. That is why I told you, because the right ventricle depolarizes last, you'll have the S wave only being terminally delayed. So this is called the slurring of the S wave. Okay. So this is the complete right bundle branch block. Then coming to the left bundle branch block. Okay. So just like the right bundle branch block, now the left bundle branch has an abnormality. So the impulse will come through the His bundle. After the His bundle, because the left bundle branch is blocked, it has to come down the right bundle branch. So it comes down the right bundle branch. Now the septal depolarization, which normally takes from left side of the septum to the right side of the septum, cannot happen. Okay, because the left bundle branch block is there. So therefore, the initial septal depolarization does not happen. So the initial part of the QRS complex is delayed. The next, the right ventricular depolarization will happen normally because the right bundle branch is normal. So the middle part of the QRS complex does not have any delay. It is normal because the right bundle branch is normal and the right ventricle depolarized to the normal Purkinje system. Then next is the depolarization of the left ventricle. The depolarization of the left ventricle happens long after the depolarization of the right ventricle, and it happens by the cell-to-cell conduction because of the left bundle branch block, and hence the terminal part of the QRS complex is delayed. So in the case of the left bundle branch block, the initial part of the QRS complex is delayed due to the absence septal depolarization. The middle part is normal because the right ventricular depolarization is normal, and the terminal part is delayed due to the delayed left ventricular depolarization. So because the initial portion and the terminal portion is delayed of the QRS complex, it looks like the whole QRS complex is delayed. So in contrast to the right bundle branch, where only the terminal part of the QRS complex is delayed, here the entire QRS complex is delayed in left bundle branch. Okay. So because the initial septal depolarization is absent, you have absent Q waves or absent normal initial forces in the lateral leads like 1 AVL and B6. Okay. And because the depolarization pattern happens from right ventricle towards the left ventricle, you will have a negative wave, that is a QS wave in V1 or a small r deep S wave in V1. Okay. And because of the delayed QRS complex, delayed QRS, delayed depolarization of the left ventricle, you have a notched R wave in V6. Okay. And the M pattern, which you see in the right-sided leads and right bundle branch block, here you have in the left-sided leads. Okay. So you will have the M pattern in lead 2, lead V6. So again, coming to the left bundle branch block. So when the impulse comes towards the his bundle, the left bundle branch is blocked. So it has to come down the right bundle branch. The initial septal depolarization is absent. Okay. And the after the right ventricular gets depolarized, then the depolarization goes towards the left ventricle, and that depolarization of the left ventricle is delayed due to the left bundle branch block. So the entire QRS complex is the duration is prolonged. So you will get a deep QS wave in V1 and a very wide QRS complex with a notched R pattern, notched R wave in V6. Okay. So this is the QS or the RS pattern in V1, and you have the notched R pattern in V6 with the absent septal Q wave. So this is the left bundle branch block. So here we have an example. You can see the deep QS pattern in V1, and you can see the notched R wave and absent septal Q waves in the lateral waves V6, and also they will present in the inferior leads because the left ventricle is also inferior to the right ventricle. Okay, so they have the M pattern in the even the inferior leads like 2, 3 ABF and also in V6. So this is the left bundle branch block. Of course, the QRS duration is prolonged more than 120 milliseconds. Then coming to a bifascicular block. So bifascicular block is basically, you know that the left bundle branch, when I discussed the anatomy of the conduction system, the left bundle branch had a left anterior fascicle, left posterior fascicle, and septal fascicle. So sometimes when the only one of the fascicles is blocked, so you have a left anterior fascicle block, which is called a left anterior hemiblock, in association with a right bundle branch block. This is called as a bifascicular block. Okay, so in the right bundle branch block, you will have the RS-R dash pattern in V1, and the left anterior hemiblock will cause a small R and a deep S wave in inferior leads with a left axis deviation. So if you have the same pattern RBB with a right axis deviation, it will be a right bundle branch with a left posterior hemiblock. Okay. So there's also something called as a trifascicular block. So a trifascicular block is present when you have the same pattern RBB with left anterior hemiblock or left posterior hemiblock with a prolonged PR interval. So trifascicular block is very sinister and needs a pacemaker. Okay, so these are bifascicular blocks and trifascicular blocks. So in coming a 5-year-old boy with recurrent episodes of tachycardia. If you remember this ECG, you have seen this ECG in previous class. So the findings of this ECG is you have a short PR interval over here. Okay, you have a wide QRS complex, and you have the slurring of the upstreak of the QRS complex known as the delta wave. Okay, so this is the WPW syndrome, classical findings of W syndrome. And now we'll explain why each and every finding happens. So you know that in the left-sided picture, the normal depolarization will happen from the sinus node, internodal tracts, AV node, his bundle, right bundle branch, left bundle branch, and normally through the Purkinje system. The only connection between the atria and ventricle electrically is through this AV node and his bundle. There is no other electrical connection. But in the case of a WPW syndrome or Wolff-Parkinson-White syndrome, you will have an abnormal connection between the atria and ventricle known as the atrioventricular bypass tract. Okay, so this will connect the atria and ventricle other than the AV node. So now the sinus node can very well from the atria, it can go through this abnormal bypass tract to the ventricle and depolarize the ventricle. So because this bypass tract will travel faster than the normal AV nodal conduction system, that is why the atrial impulse will reach the ventricular atrial impulse will reach the ventricle sooner. So that's why you have a short PR interval. And because this will this impulse depolarize the ventricle to the abnormal tract and not through the normal conduction system, the QRS complex will be wide because the subsequent ventricular depolarization will be by myofiber to myofiber conduction. And why do you get the delta wave? You get the delta wave because the QRS complex is depolarized by both the normal AV nodal conduction system and the abnormal atrioventricular bypass tract. So the three findings of short PR interval, delta wave, and wide QRS complex we have now explained. But why do these patients prone for recurrent episodes of tachycardia? So what happens is, I have to explain that this normal AV nodal conduction system and this accessory bypass tract, they have different conduction velocities and different refractory periods. Normally, the commonest type of WPW syndrome will have the bypass tract will be having a faster conduction time and a longer refractory period. Okay, so suppose you have a premature atrial complex, which happens before the next impulse happens from the sinoatrial node. It comes towards this portion. Now it has a this premature atrial complex has a choice. It can go down the AV nodal pathway, or can go down the accessory bypass tract. But when it reaches this portion, it finds that this accessory bypass tract has a longer refractory period, so it cannot conduct down this tract. So it will now conduct down the normal AV nodal conduction system, and then by the time it reaches the bypass tract, it deploys the ventricle and reaches the bypass tract. The bypass tract refractory period would have recovered, so it goes up the bypass tract, depolarizes the atria, and comes down again. So this is a re-entrant pathway. So this causes the tachycardia, known as the atrioventricular re-entrant tachycardia. So that is why these patients are more prone to supraventricular tachycardias. Now coming to we're going to discuss about the right ventricular and left ventricular hypertrophy now. So you have to know about the frontal plane leads the positions and the horizontal plane leads the positions. So the AVR lead 3 will mainly be the right ventricular forces. Okay, and AVL lead 2 will be the left ventricular forces by the direction. And V4R, V1 and V2 will be over the right ventricle, and V5 and V6 will be over the left ventricle. Okay, so QRS amplitude abnormalities are, you can have tall R waves in either V1. So because V1 is over the right ventricular hypertrophy means tall R waves over V1, and left ventricular hypertrophy means tall R waves over V6. Then you can have deep S waves. So if you have deep S waves over V6, that means it's the opposite, the right ventricular hypertrophy. And if you have deep S waves over V1, it is the left ventricular hypertrophy. Because the V1 is over the right ventricle, if it's a left ventricular hypertrophy, you will have deep S waves because the vector is going opposite. Okay, so basically a right ventricular and left ventricular hypertrophy are diagnosed by means of tall R waves and deep S waves. So most of the criteria are based on this. Sometimes you can have a small amplitude QRS complex. So small amplitude QRS waves are basically defined by less than 5 millimeter in the limb leads and less than 10 millimeter in the chest leads. So if you have a diffuse myocardial disease, like for example a myocarditis, we have a lot of myocardial edema, or you have a pericardial effusion, a lot of fluid surrounding the heart, those depolarization wave fronts cannot reach the ECG leads very effectively because of the intervening myocardial edema or the pericardial effusion. Same way, if you have a patient who has a COPD, chronic obstructive pulmonary disease with a lot of air, or a very obese patient who has a lot of subcutaneous fat. So all of these patients, because the impulses cannot reach the ECG leads effectively, you will get a small QRS complex. Okay, so these are complex examples of small QRS complex. So criteria for left ventricular hypertrophy and right ventricular hypertrophy in adults. So you have many criteria, and they're all given in standard textbooks, but most of them just are the same things, like tall R waves and deep S waves, a combination of those. So for example, the important ones in left ventricular hypertrophy are the Sokolov-Leon voltages, where you have a deep S wave in V1 and tall R wave in V5 more than 35 millimeter, or a deep tall R wave in AVL more than 11 millimeters. So you have many criteria. Same way in right ventricular hypertrophy. If you have tall R waves in V1, which is overlying the right ventricle more than 6 millimeter, or increase R by S ratio, or deep S waves in V5, V6, they will be right ventricular hypertrophy. So you can refer to the standard textbooks to know the criteria for the adults. Now, regarding the children, actually, it's a little bit difficult. So as we know that children, for example, a 3-year-old boy has a particular height and a weight. So they will have a mean height and weight for that age group and a standard deviation or percentiles. So above this, you know that he is having increased height, or below this having less height. So same way, there are actually tables which are present, which shows what is the normal R wave and what is the normal S wave in each lead for every age group, and what is the standard deviation. But these tables are very impractical. You cannot, each time when you see an ECG, you cannot go and refer the tables. So there are certain hints which tells that there's a right ventricular hypertrophy or left ventricular hypertrophy in a child. So if an R wave in V1 is greater than 20 millimeters, it is a right ventricular hypertrophy. If the S wave in V6 is more than 10 millimeter in less than 1 year, or more than 5 millimeter in more than 1 year. So why it's more than 10 millimeter in less than 1 year? Because you know that right ventricle is more dominant in the infant and the neonate. Okay. and abnormal QRS configuration. So if you have a QR pattern in the V1 or a monophasic R in V1, so this can also be a right ventricular hypertrophy. This is both in the child and in the adult. If you have an abnormal right axis deviation, okay, can be right ventricular hypertrophy. Then coming to the T wave. So the T wave morphology changes in V1 as you go from the newborn to the adult. So normally in the newborn, in the first week of life, the T wave will be upright. Then after the first week of life, up to 6 to 8 years or up to adolescence, the T wave becomes inverted in V1. And after adolescence, it becomes upright again. So in the period of 1 week to 6 to 8 years of adolescence, the T wave is normally inverted. So there, if you see an upright T wave, it is quite a good sign of right ventricular hypertrophy. So this is especially for the pediatric age group. So always remember, in neonates, RV is more dominant, and the RV dominance is slowly replaced by LV dominance during childhood, and that is why you have different criteria or different millimeter voltages for the child when compared to adult. So in newborn, you know that the right ventricle, is more dominant. So therefore, it is difficult to diagnose a right ventricular hypertrophy in a newborn. But there are certain factors. For example, if you have a QR pattern in V1, if you have a monophasic R wave, so you have only an R wave and no S wave in V1, more than 10 millimeter, or R in V1 more than 25 millimeter, R in AVR more than 8 millimeter, or if you have an upright T wave after the first week of life, which we will explain, and you have a right axis deviation. So, in a newborn, the right axis deviation can even go up to 180 degrees, the normal axis, sorry. So, if you have a right axis deviation more than 180 degrees, it means a right ventricular hypertrophy in a newborn. So, these problems happen because the newborn normally has a right ventricular dominance. So, you have to use a separate criteria. Now, some examples of a right ventricular hypertrophy. Okay, so now you see this ECG, you have a tall R wave in V1 and a deep S wave in V6. So definitely it is a right ventricular hypertrophy. Associated with that, if you have abnormal ST changes, STT changes, so if you have depressed ST segment or T wave inversions, it means that the right ventricular hypertrophy is even more significant. So here you can see ST depressions and T wave inversions in most of the leads, V1 to V3, V4. So it is a severe right ventricular hypertrophy. So this is a boy with a grade 4/6 ejection systolic murmur in the left upper sternal border. So it was diagnosed as a pulmonary stenosis. So here you have the typical QR pattern in V1. So this QR pattern in V1 means that there's a severe right ventricular hypertrophy. So this patient needs quite soon intervention for the pulmonary stenosis. And also you have a T wave inversion and ST segment depression in the V1 to V4. Okay. So coming to the left ventricular hypertrophy. So the left ventricular hypertrophy criteria are somewhat similar for the children and for the adults. So basically a tall R wave in V6 or a deep S wave in V1. So R waves in V6 more than 25 to 30 or S waves in V1 more than 20 to 30 millimeter. And it's important to know that if an tall R wave is present in a V6 without a tall R wave in V5, it is less specific for the left ventricular hypertrophy because the V5 is the one which is present of the left ventricular apex. So R waves over V5, tall R waves over V5 are more specific than tall R waves over V6. And if this tall R waves in the V5, V6 are present along with the STT changes, it is more significant of left ventricular hypertrophy criteria than if the STT changes are not there. Then abnormal QRS configuration, if you have a QS pattern in V1. Then coming to the diastolic volume overload, the next point. So hypertrophy can be pressure hypertrophy or volume hypertrophy. So in the case of conditions like aortic stenosis, okay, or systemic hypertension, it is a pressure hypertrophy. But in the case of conditions like mitral regurgitation, aortic regurgitation, or a BSD, PDA, there is a volume overload or a volume hypertrophy. So these conditions will usually have a deep Q wave in V5, V6 more than 5 millimeter along with tall T waves. So that means a volume overload. Okay, so that is a volume overload for the left ventricular hypertrophy, and also a left axis deviation. So a left axis deviation can also signify left ventricular hypertrophy. Abnormal STD changes like ST depressions in precordial leads or T wave inversions in precordial leads also signify more that there's a left ventricular hypertrophy than if these findings are not there. So this is a 50-year-old with a severe hypertension. Immediately you can see that there's a deep S wave in V1 and a tall R wave in V6. Okay, so this is a left ventricular hypertrophy. But here you see that the ST segment and the T wave are actually normal. There is no changes. Next, in contrast to this boy, a 15-year-old boy with a heaving apical impulse, a grade 4/6 ejection systolic murmur in a right upper sternal border, and also having a delayed peaking carotid impulse. So this patient is having a aortic stenosis. Okay, so this immediately you see that there's a deep S wave in V1 and a tall R wave in V6, along with the T wave inversion and ST depression. So STT changes are there. So this patient has a left ventricular hypertrophy with strain pattern. So when you have the left ventricular hypertrophy along with these STD changes, it's called as a strain pattern. So this gives more significance to the severe aortic stenosis and treatment needs to be done quite soon than if the STD changes were not there. Now a 6-month-old child with a large VST. Immediately again you see the deep S waves in V1 and the tall R waves in V6. But now you see the deep Q waves in V6 along with the tall T waves. Okay, so this is the volume overload pattern. So we know that a VST will have a left atrial and left ventricular enlargement. So this ECG just shows us that the VST is significant because there's a left ventricular volume overload pattern. Okay, so LVH with volume overload. Now coming to the QRS voltages and configuration. Biventricular hypertrophy. That is, what is a biventricular hypertrophy criteria? So if you have criteria present for both right ventricular hypertrophy and left ventricular hypertrophy, it is biventricular hypertrophy. For example, if you have a positive criteria for right ventricular hypertrophy with a tall R wave in V6, or we have positive criteria for a left ventricular hypertrophy with a tall R wave in V1, that means biventricular hypertrophy is there. But the important one named phenomenon is called as a Katz-Wachtel phenomenon. So if you have a tall R wave and a deep S wave in the mid precordial leads, that is V2 to V4, more than 45 to 55 millimeter, this signifies biventricular hypertrophy. So consider this ECG. This is a 2-year-old with a large VST. Okay, immediately see the mid precordial leads like V2 and V3. So you have a tall R wave and a deep S wave. But if you see this, the R wave, tall R wave plus the deep S wave comes only to around 30 millimeters. So it's not satisfying the criteria of the Katz-Wachtel phenomenon. But always pay attention to the standardization. So the second half of the standardization box is showing that is 5 millimeters, which means that the chest leads are only half standardized. So if you put them full standardized, then definitely the tall R and the deep S waves will come to 60 millimeters. So now this is a Katz-Wachtel phenomenon is satisfied. So this is a 2-year-old child with a large VST and a biventricular hypertrophy. So this is actually not very good for the patient because we know that the patient with a large VST should have a left atrial and a left ventricular enlargement. But this patient is also having a right ventricular enlargement. And normally in a VST, the R waves in V1 should not be prominent, and you should have more prominent waves in R waves in V6. And there's also an absence of a Q wave. Okay, so this patient with the large VST is going towards a Eisenmenger syndrome. So that is why his right ventricle is becoming more dominant than the left ventricle. So even by the ECG, we are seeing that this patient is more likely not being able to be operated because he's going towards the pulmonary vascular obstructive disease or Eisenmenger syndrome. In contrast to the previous ECG, where we saw the 6-month-old child with a VST who's having a volume overload pattern. So that patient is most likely to be operable. So coming to the Q waves. So we know that the Q waves represent the septal depolarization. Okay, so the initial septal depolarization happens from the left side of the interventricular septum to the right side of the interventricular septum. So this septal depolarization will go rightward and superiorly because the right ventricle is anterior, rightward and superiorly to the left ventricle. So the Q waves you will get in the inferior leads and the lateral leads. So 2, 3 AVF and 1 V5 and V6. Okay, you will normally not get Q waves in the right sided leads like the V4R and V1. So a normal Q wave, the depth should be less than 5 millimeter and the duration should be less than half a small box, that is 0.02 seconds. If it is more than 5 millimeter or more than half a box, it is an abnormal Q wave. So deep and wide Q waves you will get in left ventricular hypertrophy, which is so the volume overload, or myocardial injury, like for example a myocardial infarction or a hypertrophic cardiomyopathy. So consider the 60-year-old patient coming with a chest pain, hypotension and bradycardia. Immediately what we can see is the deep Q waves. So the deep Q waves are present in leads 2, lead 3 and AVF, okay, along with ST segment elevations in lead 2, 3 and AVF and ST segment depression in lead V2 and V3. Okay, so we'll come to the ST segment later on. Okay, I just want to turn your attention to the deep wide Q waves in lead 2, lead 3 and AVF. So when you have a deep wide Q wave along with an ST segment elevation in a patient, it means the patient is having a myocardial infarction. So by knowing which leads the deep wide Q wave and the ST segment elevation are present, we can diagnose where exactly is the myocardial infarction. For example, we know that the 3 coronary arteries are 3 in number. You have the left anterior descending, the left circumflex artery and the right coronary artery. So the right coronary artery will usually supply the inferior portion of the heart or the infroseptal portion. So if you have those changes in the inferior leads, you have a inferior wall myocardial infarction due to a blockage in the right coronary artery. the left anterior descending artery will usually supply the anteroseptal portion. So the V2 and V3 leads, if you have these changes, it is due to a blockage of the left anterior descending artery. And left circumflex artery, it supplies the lateral leads. So if you're in the lateral leads, you have these combination of findings of deep Q waves and ST segment elevation. That means the LCX is blocked. So now we have the deep wide Q waves in the inferior leads along with the ST segment elevation. So this is the inferior wall myocardial infarction. Okay, most likely due to a blockage of the right coronary artery. That is supposing that the right coronary artery is dominant. So now we come to the ST segment and T wave. So the ST segment is the isoelectric point between the QRS. It is a segment between the QRS complex and the T wave. So we know that the ventricular depolarization is the QRS. T wave is the ventricular repolarization. So the ST segment is the period between the ventricular depolarization and repolarization. And what is the J point? The J point is the junction between the QRS complex and the ST segment. So both the J point and ST segment are very important for diagnosing these STT changes, like for example, a myocardial injury or a myocardial infarction. So when coming to the type of ST segment, you have two types over here. One is the smiley face, that is the concave ST segment elevation, and one is the frowning face, that is the convex ST segment elevation. So usually the sinister ST elevations are the ones which have the frowning face or the convex type of ST segment elevation. Usually the concave ST segment elevations can be normally present in some patients, like for example, the early repolarization syndrome, which can normally present in children or athletes. But having said that, sometimes even myocardial infarctions can also have the concave type of ST segment elevation. So consider this 4-year-old child with history of viral exanthem presented in congestive heart failure. Okay, so he had a fever, a rash, and then presented in congestive heart failure after 3 to 4 days. So you can see these ST depressions and T wave invasions in multiple leads, in the inferior leads and in the lateral leads. Okay, so this multiple STD changes in multiple leads in the clinical scenario of a viral exanthem presenting in congestive heart failure is a myocarditis. Okay, and coming to early repolarization. So in the early repolarization, you will have basically a J point elevation with a concave up sloping ST segment or the smiley face. Sometimes you can also have a convex, but that is less likely. And usually this ST segment and J point elevation will happen in the inferior leads and the lateral leads, less likely in the limb leads. And the important distinguishing feature from the myocardial infarction is, number one is a myocardial infarction will happen in the territory of the coronary artery, which is blocked, and you will have reciprocal ST segment changes in the myocardial infarction, but will not happen the early repolarization. So that I will explain later on when we come to the ST segment ECGs. So usually the J point is only elevated in the early repolarization syndrome, but if the ST segment beyond the J point is fully elevated or depressed, then it more likely suggests an inflammation or an ischemia or injury. So this is a child who had this ECG. So you can see the J point elevation and the ST segment elevation in the inferior leads and also in the lateral leads, V5 and V6. So this is in multiple territories and there's no reciprocal ST depression. So this is a early repolarization syndrome. Now again, coming to the same ECG which we saw before. So I told you that you have the Q waves in the lead 2, 3 and AVF, and you have the ST segment elevations in the lead 2, 3 and AVF. Okay, and you have a ST segment depression in the lead V2 and V3. So what happens is, if you have a myocardial infarction, for example, this patient is having a right coronary artery blockage or an inferior wall myocardial infarction, you will have a deep Q waves in that segment along with ST segment elevations in that segment. Now that is because the current of injury is traveling towards the depolarization wavefront is traveling towards the leads which is over the infarcted segment. So the leads which are opposite to the infarcted segment, so opposite to the inferior wall will be the anteroseptal wall. So because the depolarization wave is traveling towards the infarcted segment and away from the opposite leads, you will have an ST segment depression in the anteroseptal leads. So here in inferior wall myocardial infarction, you will have a ST depression in the anteroseptal leads. So this is the reciprocal ST changes. So when you see a myocardial infarction, you will have the ST elevation in the leads which overlay the territory and the reciprocal ST depression in the electrically opposite leads. This is how you diagnose a myocardial infarction. So this is a 30-year-old lady underwent an ASD surgical closure, post-operatively developed chest pain on day 2. So here you can see an ST segment elevation, but it is present in multiple leads. It is not confined to any territory. Lead 1, lead 2, lead AVL, and even almost all of the precordial leads. So definitely it cannot be a myocardial infarction. All the coronary arteries is very rare to get blocked at the same time. But along with this, you also have another segment, finding. This is called as the PR segment depression. So PR segment depression you can see in lead 1, lead 2, and lead AVF. So when you have ST elevation in multiple leads along with PR segment depression, it is classified for a pericarditis. And in the clinical scenario of a patient having an ASD surgical closure, pericarditis is quite common in the post-operative period. So when you see this ECG, you don't have to get alarmed. You can just give symptomatic treatment like NSAIDs. You don't have to take the patient to a cath lab and do a coronary angiography suspecting that it could be a myocardial infarction. So coming to the T waves. So the T waves represent a ventricular repolarization phase. Okay. Usually it has a slow upstroke and a rapid downstroke. The T waves are usually inscribed in the same direction as the QRS, but in conditions like, for example, a right bundle branch or left bundle branch block or a myocardial injury, the T waves can be inscribed in the opposite way. So tall peak T wave. So there's no definition actually for a tall peak T waves, but usually if the T wave is more than half of the QRS height, then it is a tall peak T waves. So tall peak T waves can be present in hyperkalemia, left ventricular hypertrophy, or a stroke. Flat or low complex T waves can be present in cardiomyopathies, pericarditis, myocarditis, hypokalemia, and sometimes in digitalis effect. Okay, and abnormal T wave morphology can be present in long QT syndrome, like Knox T waves, bifid T waves, or broad-based T waves. They abnormal increased T wave duration or T wave alternance. All these can be present in prolonged QT syndrome. So in the T wave evaluation, there's a way in which the T wave evolution goes. So when considering the T wave in B1, in the first week of life, usually the T wave will be upright, but sometimes it can be also inverted. But after the first week of life, up to 6 to 8 years or up to adolescence, the T wave will be inverted in B1 and upright in B5, B6. And after adolescence, it becomes upright in B1. So that's why we diagnose in a right ventricular hypertrophy after 1 week of life. If the T wave is upright in B1, it is a right ventricular hypertrophy. So T wave inversion in the lateral leads or left precordial leads suggest hypertrophy, ischemia, inflammation. So this is a 6-year-old child presenting with acute glomerulonephritis, systemic hypertension, and renal failure. Okay, so immediately you can see this patient is having very tall peak T waves, which is more than the half of the height of the QRS complex. So when you check the potassium of this patient, it was high with 6.3 millimoles per liter. So this hyperkalemia was corrected after T waves became normal. Another patient who's having a dilated cardiomyopathy, an example of the flat T wave. So you can see the T waves are very flat in the precordial leads. And also the dilated cardiomyopathy can sometimes called low voltage QRS complexes. So you can see the QRS complexes are low voltage in the limb leads and in some of the precordial leads. Okay, that is due to the dilated cardiomyopathy. Okay, and next is the hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy can have very large complexes in all the precordial leads, and it can have deep T waves, deep inverted T waves in the lateral precordial leads. So this is an example of a hypertrophic cardiomyopathy. Then coming to the electrolyte effects on the ECG. Okay, so electrolyte effects on the ECG, usually potassium and calcium are the ones which cause an ECG changes. Excuse me. Coming to the hypokalemia. So when potassium becomes less than 2.5 milliequivalents per liter, the first thing which happens is the T wave becomes flattened. Okay, so this is the flattened T wave, and then a prominent U wave, which is another wave which can be present after the T wave. It is thought to be due to His-Purkinje repolarization. It can be a normal phenomenon, but in hypokalemia, the U waves become more prominent. And usually the morphology of the U wave will be the same as the preceding T wave. So if T wave is positive, U wave will also be positive. So here you see the T wave has become flattened, the U wave has become more prominent, okay, and the ST segment has become depressed. So these are the findings of hypokalemia. Now, if hypokalemia becomes even more progressive, then you can even have a prolonged PR interval and you can have a sinoatrial arrest. So when coming to hyperkalemia, as the potassium level goes up and up, you will have a tall peak T wave, which we saw in our patient. Then if it goes more than 7.5 millimeter, the QRS complex becomes widened, which is called as an intraventricular conduction delay, and PR interval becomes prolonged. So when potassium goes even more, you will have a loss of the P wave and a sinusoidal wave. Okay, so these are and even more if the potassium you're not able to correct, it will finally lead to ventricular fibrillation. Coming to the serum calcium. So serum calcium, the hypercalcemia and hypocalcemia usually will affect the the ST segment or the QT interval. So hypercalcemia will cause a short QT interval and hypocalcemia will cause a long QT interval. But the difference between this and the hypocalcemia and the prolonged QT syndrome is the hypocalcemia will only affect the ST segment. It will not alter either the morphology of the T wave or the duration of the T wave. But prolonged QT syndrome will alter the duration of the T wave or it will alter the morphology. Like it can cause a notched T wave, it can cause a broad-based T wave, or a increased T wave duration. So coming to the normal variations in children when compared to adult. So there's a more right axis and right ventricular dominance in the newborn when compared to the older age group. The transition between the right ventricular dominance to left ventricular dominance happens between 1 month to 3 years of age. And after 3 years of age, usually it becomes like the adult. But premature infants will have a less RV dominance when compared to the term infants. And the differences of the T wave, I've told that there's a T wave becomes negative after the first week of life in V1 up to 8 years of age, and after that it becomes positive. And something called as juvenile T wave inversion. So usually T wave after 8 years of life should become upright in V1, and T waves can normally be inverted up to lead V3 in children. So T wave inversion up to V3 is taken as a normal thing in children. This is called as a juvenile T wave inversion. And early repolarization syndrome, which we have seen, along with a first degree AV block and Wenke back, they can be normally present in children or in athletes. So normal variations in athletes, you can have a sinus bradycardia, a sinus arrhythmia, junctional rhythm, or ectopic atrial rhythm. You can have an early repolarization syndrome, and you can have normally you can have a criteria satisfying left ventricular hypertrophy in athletes. So because athletes exercise a lot, they will have a high muscle mass of the heart, especially of the left ventricle. So they will have tall R waves and deep S waves, criteria for left ventricular hypertrophy. But mind you that left ventricular hypertrophy should not be associated with the left axis deviation, or left atrial enlargement, or STT changes. If it's associated with these criteria, then it means the LVH is abnormal in that athlete. So as I told you before, children have, according to the age group, the height and the age and the weight, according to the age group, the height and the weight of the child will vary. Similarly, the calculation of the R wave voltages and the S wave voltages in the different leads will also vary. So here is a table which is taken from a standard textbook. For example, from 0 to 1 month up to 12 to 16 years in young adults, it gives the mean value and the upper limit of normal, both for the R waves and the S waves. So as I told you, it is not practical to have this table next to us and go on referring for each ECG to see what are the normal R and S waves. So I've just told you a few pointers, and I've told you a few values which are abnormal for the newborn and for the child. So you can follow that. Thank you very much for the patient hearing.
Thank you so much, sir. That was really a very beautiful presentation.
Thank you, Dr. Kar. So I've not I've not covered in this presentation congenital heart disease ECGs and arrhythmias. So maybe if the management wants, maybe we can do that in the next class, or do it sometimes later.
Definitely, sir. We'll discuss and we'll schedule it for the next week.
Okay.
Thank you so much, sir. We can stop your screen sharing.
Okay, thank you very much. I hope it was clear.
It was very clear, sir. First part, you made it everything clear with the basics, and second part, it was fully clinically you explained everything with the case histories.
Thank you very much, Dr. Kar.
It was really good, sir.
Okay. Shall we conclude the meeting, or should we wait for some time?
Yes, sir. Yes, sir. We can conclude the meeting. I have some few announcements for the
Okay.
audience.
Okay. Thank you very much, Dr. Karthik. Okay.
Thank you so much, sir.
So maybe you can give them my email. If there's any doubts, they can email me about any questions they might have.
Definitely, sir. So far, we don't have any doubts in the comment section. In future, if there is any doubts, we'll contact you, sir.
Okay. Thank you very much, Dr. Karthik. And thank you, everybody, for the patient hearing.
Thank you, sir. Okay, viewers, that was really a good presentation. And I have few more announcements before we wind up the session. And I hope you all enjoyed the session with from the sir. Please spread the word to all of your friends. You can see the YouTube channel page here, link here. Please share it with your friends. And the FB page link, fb.com/Indian Medical College 2020. You do follow here. We are posting all the recorded videos on the MCQs, and important announcements will be posting in the FB page. So please do follow in FB page and share it to your friends. And tomorrow also we are having some good sessions. First session will be about the IM and CI facility based. And that is integrated management of newborn and childhood illness. This will be delivered by Dr. Somasegar. And session 2, 6:30 to 7:30 p.m. Drugs in peptic ulcer. This will be delivered by Dr. Ramya Ravichandar. Thank you all. Thank you for joining. Have a nice day.